Morning, everyone. Today's CEU session, we'll be looking at how to use the grade tool to analyze a systematic review. So today's outline, first we'll go through an introduction to what is grade and what are the components of grade. In the second part of our presentation, we'll try to use grade on a sample systematic review so we can practice how to use it. Start with the case scenario. 35-year-old man has presented with paresthesias of the fourth and fifth fingers, pain at the elbow, weakness of the flexor carpi ulnaris, and the medial half of the flexor digitorum prominens. Nerve conduction studies have diagnosed an ulnar nerve entrapment syndrome at the elbow. Now, the surgical treatment options for this patient are mainly surgical. These include surgical decompression of the nerve at the elbow, which could be endoscopic or open. Between these two, which option do you recommend to this patient? To answer this question, we'll be looking at a Cochrane review, which was published in April 2025, which is a review of all possible treatments for ulnar neuropathy at the elbow. The PICO statement for the systematic review is that they had looked at patients more than 18 years of age who have been diagnosed with ulnar nerve entrapment syndrome based on either clinical or radiological or based on nerve conduction studies. The interventions they had looked at was all forms of surgical and conservative treatments, which included splinting, corticosteroid injections at the elbow, and rest. The outcome measures they had used to assess the effectiveness of these interventions were mainly the Bishop score, the McGowan score, and the SF36 score. These are all scores of nerve function which are assessed preoperatively and postoperatively. And for example, with the Bishop score, which is the one used in most of the studies, an improvement of more than 2 is considered significant. Primary outcome that they looked at was a clinical improvement in motor function as compared to the baseline. The types of studies they had recruited for this analysis was mainly RCTs and quasi-randomized studies. So this is an update of a previous review, which was first published in 2008, then was updated a second time in 2015. This is an update of a systematic review that was first published in 2009, was then updated second time in 2015. This is the third update in 2025. So they have identified a total of 6 new studies, which they have included to the 9 previous studies in the 2015 update. The results of the study, they have looked at multiple outcomes. 2 studies that have looked at our outcome of interest are Schmidt in 2014 and Krejci in 2018. These were the ones that were RCTs that have compared open decompression versus endoscopic decompression. The results they have given in the form of a forest plot. We can see that both Krejci 2018 and Schmidt 2014, the relative risk lies along the line of no significance. There does not seem to be any great benefit of either open decompression versus endoscopic decompression. Whereas these 2 same studies, they had also looked at the hazards of the intervention. What is the risk of hematoma versus what is the risk of scarring? Is it more in open decompression versus is it more in endoscopic decompression? Now, if you look at the hazards, there seems to be that seems to favor open decompression. But if you look at the number of events in Krejci 2018, there have been 0 outcome events in endoscopic decompression and only 5 in open decompression. The Schmidt had more number of outcome events in endoscopic and in open decompression. So that seems to have skewed the results a bit, which is why the overall outcomes seem to favor open decompression. Now, at this point, we will use the grade tool to assess the certainty of the underlying evidence. The systematic review has already used the grade tool. They have given us a table in this form, where if you look at this last column, they have graded the outcome of clinical improvement as moderate certainty of evidence, and the adverse events outcome, they have graded it as a low certainty of events. Now, today we will look at how to use this grade tool and how they reach this conclusion of moderate certainty and low certainty. So what is grade? It's a system that was developed and updated by the grade working group. It expresses the degree of confidence that someone can place in the quality of the evidence and the strength of the recommendation. It's a systematic way of assessing the quality of evidence based on the study design with specific criteria for either downgrading or upgrading the quality. Now, where do you use grade? When you are forming guidelines for a research question, the first step is to formulate the PICO question, select the outcomes of importance, prioritize the outcomes, and finally, then we will look at systematic reviews that have looked at our outcome of interest. Then we synthesize an evidence profile. Now, at this point is where grade comes into play. Once you have the evidence profile, you rate it using the grade tool based on certain criteria which we will come to. These findings and the gradings are then presented to a guidance panel who will then vote on whether on either for or against an action. How based on how certain the evidence is, they'll either give a strong recommendation or only a conditional recommendation. Why should we bother grading evidence? Because people draw conclusions about the quality of evidence and the strength of recommendations. And the systematic approach to this will help facilitate critical appraisal. It will help protect against errors. It will help resolve disagreements. Because it's done in a systematic fashion, anyone can look at how the panel has come to their conclusions about the strength of the evidence. So what exactly are we grading by using the grade tool? We are grading two things. One is the quality of the underlying evidence. We can say that we have no confidence in the underlying evidence, or we can say we are completely confident in the underlying evidence. The second thing is the strength of recommendation. You give it a strong recommendation or a weak recommendation. So these two things are different. Can have a guideline with a very low quality of evidence, but a strong strength of recommendation. For instance, if you look at the use of ASV in snake bites, there are no RCTs comparing ASV versus conservative treatment. We do have a lot of observational studies which would automatically be classified as low quality of evidence. The strength of recommendation for ASV would be a very strong recommendation because we have seen that there are a huge number of observational studies, and because the outcomes have shown to be good, we would grade that as strong strength of recommendation. At the same time, you can have a very high quality of evidence, but if the intervention was very expensive, then the strength of recommendation would be very weak. So what is grade? It's a degree of confidence in the estimate of an effect. You can grade the evidence as either very high, which is 4+, or very low, which is 1+. What determines the quality of evidence? The study design mainly determines it. Any RCT will start as high quality of evidence with 4+. All other study designs start as low, that was 1+. There are certain factors that can either decrease the quality of evidence or they can increase the quality of evidence. We will come to those in subsequent slides. Like you said, there are 5 things that can lower the quality of evidence. One is the risk of bias, inconsistency, indirectness, imprecision, and publication bias. Depending on how severe each of these biases are, you can either give it a score of -1 or -2. So an RCT would automatically start off as high quality of evidence. Then based on the grading of these 5 factors, either give it a -1 or +1, that would one step by step reduce the quality of evidence. Observational studies, case reports, all these start as low quality of evidence. Observational studies, though they start off as low quality, there are certain factors that can improve the quality of evidence, which are whether if it's a large effect, whether a dose response curve has been noted, and the direction of the confounding biases. Depending on these 3 things, we may actually upgrade observational studies to a high quality. Now, what is the risk of bias? Risk of bias are limitations in study design and execution based on quality appraisal of the individual studies. So what do you look for in these individual studies? You can use the Cochrane risk of bias assessment tool. Specifically, the things to look for are limitations in randomization, whether the authors have deviated from the study protocol, how have they dealt with missing outcome data, whether blinding was adequate, and whether there is selective reporting of the overall results. Second thing is inconsistency. What is inconsistency? Consistency basically deals with similarity of estimates of effect across studies. What are the indicators that a study is inconsistent? If there are differences in the direction of the effect, if there's variation in the size of the effect, or if the I-square value is very large. Now we know the I-square value refers to heterogeneity in a study. We have to specifically distinguish between explained heterogeneity. For instance, if one study has looked at only a young population, and the other study has looked at an older population, then we would naturally expect some differences in the outcome. That is explained heterogeneity. But if 2 studies have looked at only the same population, identical populations, identical interventions, yet there is heterogeneity in their results, that would downgrade the quality of evidence of the study. Variation in the size of the effect, if one study shows only a small improvement, whether the other study shows a very large, that would also be an example of inconsistency. For this, we would look at the forest plot and we would look at whether there's overlap between the confidence intervals. If there is significant overlap, we can say confidently that there's no inconsistency. But if the confidence intervals do not overlap at all, then there would be significant inconsistency and we would grade that evidence as -1 or -2. Again, what we said in the previous slide, if there is only a small benefit, whereas another study shows a very significant benefit, then that would also be termed as inconsistent. Looking at the I-square, I-square is a measure of heterogeneity in multiple studies. Ideally, 0 to 40% is graded as low heterogeneity, and you would not be worried. You would not downgrade evidence based on that. Anything more than 40, it would be a cause for concern, and we would probably grade lower the quality of evidence. What is imprecision? Imprecision is a consequence of the sample size and number of events. A study that has only a low number of outcome events not be considered imprecise because the study has looked at only a small number of outcome measures. The same study, if it was replicated, would probably not give you the same value. What are the indicators of imprecision? Either a small population, a small number of events, wide confidence intervals. For instance, in this study that we are looking at, confidence intervals are varying widely on either sides of the relative risk of 1. And some studies have shown only a small benefit, while others have shown a very large benefit. It's an example of imprecision. Directness. Directness is the extent to which populations, interventions, and outcomes are similar to that of the subject of interest. What are the indicators of indirectness? You can have, if there are very different populations, differences in age, differences in sex, differences in the underlying illness, that would be a measure of indirectness. For instance, if a study has looked at an intervention in only a primary healthcare center, but you want to apply that same intervention in a tertiary healthcare center, you are extrapolating the data from a primary health center to a tertiary center. That would be an example of indirectness. Lastly, what is publication bias? To look at publication bias, you look at do a funnel plot. Look at a funnel. Now we will look at the factors that can upgrade the quality of evidence. One is that if the underlying study is an observational study, but the outcome effect is very large or there's a very large benefit, then the effect is less likely to be due to chance. Second thing, if there is a dose response gradient, meaning if it's a new drug, studies that are looking at higher doses have shown a higher response in the patient groups, then that would be an indicator for upgrading the quality of evidence. Lastly, you look at the direction of confounding factors and biases. For instance, if the underlying study has a lot of confounding factors, all the confounding factors would act in a way that they would actually reduce the effect of the outcome. Despite all these confounding factors reducing the outcome effect, you still see a positive effect of the intervention, then that would be a factor for upgrading evidence, because despite all these confounding factors and biases, the study has still shown a benefit, then you can upgrade the quality of that evidence. Like I said, a large outcome effect. Second thing is that if everyone used to do badly before the intervention, then post the intervention, everyone does well. And if it's a very rapid action, for instance, you can look at hip replacement for osteoarthritis. So at the end of grading evidence, you would end up with a summary like this, where here we have factors like, for instance, in this grade table, we have looked at the use of beta blockers in non-cardiac surgeries. And the outcomes that they have looked at are myocardial infarction, mortality, and stroke. And you generate a summary of findings table based on your grade assessment, where you would grade the quality of evidence as either high, moderate, or low. Now, this is the overall level of the underlying evidence. Now, we have only looked at the positive outcomes, but what about the negative outcomes of these interventions? Whether it's a new drug or a new procedure, any new intervention would also have some harmful effects. So what do you do about these harms? Do you ignore it and look at only the primary outcome, or do you include that in your analysis as well? That is where the grading of the strength of recommendation comes into play. The strength of recommendation is the degree of confidence you have that the desirable effects of your intervention outweigh the undesirable effects. So if it's a strong recommendation, the desirable effects significantly outweigh the undesirable effects. Whereas a weak or a conditional recommendation means that the hazards or the undesirable effects are quite significant. For instance, if you look at aspirin after myocardial infarction, causes a significant reduction in the relative risk, Side effects are minimal, the cost is minimal. So here the benefit is obviously much greater than the risk, and we would give this a strong recommendation. Whereas if you look at anticoagulations versus aspirin in low risk atrial fibrillation, now anticoagulation can reduce the risk of stroke by 50%. If the But the existing risk of stroke in patients with low risk atrial fibrillation is already only 1%. So the anticoagulation would only reduce it from 1% to 0.5%. At the same time, giving anticoagulation to a large number of patients would increase the risk of significant GI bleeds by 1% per year. So this is an example where the harms would outweigh the risks. So even though there is a significant benefit, we would give this only a weak recommendation or a conditional recommendation. So what is the significance of the strong versus weak recommendation? One is that if it's a strong recommendation, then all your patients should be on the same intervention. Whereas if it was a weak recommendation, then the choice would be left to the patient as to whether they want to adhere to the new drug or intervention. And how does it change your interaction with the patient? If it's a strong recommendation, then you would just inform the patient that this is the treatment for their underlying condition. Whereas if it was a weak recommendation, then you would explain the pros and cons and the risks of hazards to the patient, and you would try to ensure that your patient makes an informed choice. We'll come to an example of how to use the grade assessment. If you go to the GradePro website, which is at gradepro.org, this is the home page that you can log in using your Cochrane account, and this is the home page that you would come to. The right-hand side, there would be a box showing import projects. You can click on that box showing import projects, and if you have the underlying data file from a Cochrane review, you can upload that data file, and that would automatically give that data, automatically enter that data. If you do not have that underlying data file, then you would have to look at the forest plot of that Cochrane review. For instance, in our example at the beginning, we have looked at this clinical effect of endoscopic excision. And the Cochrane analysis will give you the data in a forest plot like this. From this forest plot, we can manually enter the data into this box here. The columns here are: one is the clinical effect of endoscopic intervention, the clinical effect of the open decompression, what is the relative risk, and the confidence intervals. So these can be manually entered here. Now we will come to the grade assessment. Grade this. So this is the evidence. Now we will grade this quality of evidence. Now in the review, we also have the study characteristics where they have told us a brief summary of the PICO statement and the risk of bias for both these studies. We will use this to use the grade assessment tool for these studies. If you click on the first box, the first pop-up that will come up is to assess the risk of bias. Now, to assess the risk of bias, we look at the specific factors of random sequence generation, allocation concealment, blinding, outcome data, selective reporting, and other sources of bias. So if you look at the risk of bias table, now ideally we should be looking at the original article, and we do a risk of bias assessment on that article itself. For the purpose of today's lecture, we will just look at the risk of bias table that is already given in the Cochrane review. Now, if you look at the author's judgment on the risk of bias of each of these outcomes, the first study, most are at low risk of bias. There is only one outcome, which is that sample size was not calculated, which is graded as a high risk of bias. The second study, it is similar. Same thing is that there are two high risk biases. One is there is a significant reporting bias. Second thing is that the authors have not specified whether it's a superiority versus a non-inferiority. And again, here they have not calculated the sample size. So overall, it seems to be a low risk, with only the other biases showing a high risk. So here I have rated the grade assessment of study limitations is that most information is from studies at low risk or an unclear risk of bias. Now, the second thing is that because there is some factors with an unclear risk of bias, is that likely to lower the confidence in your outcome? Yes. So I have graded saying yes, because they have not calculated the sample size that may lower our confidence in the outcome estimate. So I have lowered the grading by one level. So final assessment, I have graded it as serious limitations, and I have downgraded it by one level. The second thing is that we look at inconsistency. Now here we look at, in order to rate the inconsistency, we look at these particular factors. We look at differences in direction of the effect. We look at variation in the size of the effect and whether there is a large I-squared value. So here again, based on these two studies that I looked at, I have graded the inconsistency as not serious for the first outcome. I have graded it as serious for the second outcome. Because if you remember our forest plot, The first outcome, we had narrow confidence intervals with most of the values along the line of negative, no significance. Whereas the second outcome, because it had a low number of events, the confidence intervals were widely varying. So I graded the second outcome, I have graded it as a low quality evidence. Then we come to imprecision. As we said, imprecision, in order to grade imprecision, we look at whether a small population, whether a small number of events, and whether there are wide confidence intervals. Again, the second outcome has wide confidence intervals with a small number of events. We will grade that as low for imprecision. The last one is that the other outcomes we look at are publication bias. The other three things in this column, this pop-up box, which is large effect, plausible confounding, and dose response gradient. These three things are to be looked at only if your underlying study is an observational study. Because both our studies are randomized control trials, we will not look at these three things. We look at whether there is publication bias or not. Because we have only two studies, we are not able to do a funnel plot for this. We have graded this as saying there may be significant publication bias. Once you enter the last bit of data here, the grade software will automatically generate a summary saying moderate certainty of evidence for the first outcome and very low certainty of evidence for the second outcome. Although studies that we have looked at are the same two studies have been looked at for both the first and the second outcome. If you remember, the second outcome had very low number of events, wide confidence intervals, and imprecision was significant, inconsistency was significant, which is why the second outcome has been graded as very low, whereas the first outcome has been graded as moderate certainty. Now that table you can export it into a PDF or a Word format, which will generate a table like this. Now, once we have that evidence table, that evidence will. So once we have that evidence table, now the second part of it is we have to determine the strength of our recommendation. Now, in order to do that, the second part of the grade assessment tool will give us specific outcomes to look at, not to make an assessment on the strength of the evidence. For instance, the first pop-up box shows us, is this problem a priority among our patients? My judgment I have given as yes, because ulnar neuropathy at the elbow is actually the second most common entrapment neuropathy after carpal tunnel syndrome. An annual incidence of 24.7 cases per 100,000 per second. Another question that they've looked at is, are there a very large number of resources required for this intervention? Remember, the intervention that we are looking at is endoscopic decompression versus open decompression. We don't have direct evidence from India, but there is a Finnish cost description study for ulnar nerve entrapment. There they have looked at the cost of both these interventions, and the cost of open decompression was around 3,142 euros. The cost of endoscopic decompression was 3,723 euros, which is around 600 euros more. In CMC, we don't have data for ulnar decompression, but we do open and endoscopic decompression for carpal tunnel syndrome. The open decompression costs around 80,000, while endoscopic decompression costs around 1.5 lakhs. So there is a significant large cost associated with the new intervention, which is endoscopic decompression. So each of these criteria would be graded. And at this point, at the end of this, there will be a table generated like this. For instance, the first one is a significant problem. I graded it as yes, which is dark. Now, if the outcomes that you have graded are favoring the intervention, then it would grade it as very dark blue. Whereas if the outcome is not favoring the intervention, it would grade it as light blue color or orange in color. So this table will give you a good visual representation of your grading. So the first problem which I've rated as yes, it's a significant problem which favors the intervention. It's come as dark blue, yes. The other things which are undesirable effects, this underlying certainty of evidence, and whether there's any, the overall balance of effects, the resources required, all these are favoring the control group, which is open decompression. So this is the table that will be generated at the end of your grade assessment. Now, this table would then be presented to a panel of investigators who then vote on the certainty of the underlying evidence, and secondly, the strength of recommendation. So overall, based on the strength, the quality of the evidence, and the grade assessment, I have given endoscopic assessment as a conditional recommendation against the intervention, mainly because of the costs involved. Overall, because the hazards were much more in the endoscopic decompression, we have decided on a conditional recommendation against endoscopic decompression, and we have favored open decompression. Coming back to our case scenario, which was a 35-year-old man with ulnar nerve entrapment syndrome, what would we recommend to this patient? We would recommend open decompression. So this is how you would use the grade assessment to grade the quality of evidence in a